Hi, good afternoon, everyone. It's John Snyder here for another edition of Newton-Wellesley Medical Group Lunch and Learn on this glorious November Thursday. Hopefully you guys have been able to get out and get some vitamin D and some sunshine. We're happy to invite Dr. David Rams into the hot seat today, talking to us about direct anterior approach total hip arthroplasty. Is it a superior approach? Next slide, Dave, please. We wanted to tease the upcoming Lunch and Learns. Next week is Thanksgiving. Good time to catch up on some archived Lunch and Learns. After that, we have information about the MGB Pancreas Cyst Conference, Dr. Kadan. And then after that, we're excited about Spotty Dotty, evaluation of abnormal uterine bleeding by our own doctors Angle and McGrory. And then following that, we have hip pain in the athlete or pseudo-athlete by Dr. Ethan Healy, excuse me. All these talks are archived up on Newton-Wellesley Medical Group in our intranet, as well as also on YouTube. Next slide, please, Dave. We want to also remind folks about our brand new Newton-Wellesley Hospital Thyroid Biopsy Clinic. Having patients with thyroid biopsy sometimes can be a challenge with our PCP. These patients can come to this clinic and get together multidisciplinary care with an endocrinologist, thyroid surgeon, cytologist, and radiologist in one location, one-stop service. Fine needle aspirations and follow up at that clinic under the expertise of our Newton-Wellesley physicians. Again, you can refer patients for nodules greater than 1 centimeter, suspicious nodules, FDG, avid lesions on PET scanning, or palpable nodules. Easily to refer to them through Epic by just putting thyroid biopsy in the order or calling, and there's an email address listed as well. Next slide. And then we're going to have a little fun. Speaking of pseudo-athletes, we're going to have a little fun on Sunday of Thanksgiving. We're going to hopefully ride like we did last year together on a live ride at 9:30 a.m. Jen Sherman, 45-minute cover-to-cover ride. It's a series she does with song covers. So if you're riding that day, come and join us on Sunday, 9:30. Next slide, Dave. And I'll turn it over to you. Thanks.
Great, thank you. It's a pleasure to be here with all of you today. So I'm hoping today to talk to you a little bit about the direct anterior approach, total hip, and a little bit of comparison to the posterior approach. You know, a lot of patients these days are they're doing their research on the internet, and they're coming to their doctors, whether it's their primary care provider or their surgeon, seeking an anterior approach, which they've heard great things about. So I guess the topic today is that truly, is it truly a superior approach? Is it a superior hip replacement? So let's get into it. So briefly, a little bit about me. I'm originally from Western Mass. I grew up in Northampton. I did my undergraduate studies at UMass Amherst. I went to UMass for medical school. My residency was at Tufts, and then I followed that with a fellowship in adult reconstruction at the New England Baptist Hospital. My clinical interests include, of course, primary hip and knee arthroplasty, direct anterior approach total hip. I do posterior approach hip as well. I will do partial knee replacements as well as revision hip and knee replacements as well. I'm currently seeing patients in our main office, which is in Natick on Speen Street. We also have a location in Newton-Wellesley Hospital in the Blue Building. And we also have a location down in Hopkinton at 1 Lumber Street. So, a little introduction to hip arthroplasty. It is a very effective surgical treatment for hip arthritis. In fact, some research has shown hip replacement to be the most effective surgery that is done of all surgical specialties. Overall, the outcomes with hip replacement are very good. It can be performed through several different approaches. The posterior approach is perhaps the most common approach. Alternative approaches include the direct lateral, the anterior lateral, and the direct anterior approach, which is sort of the topic of today's talk. There is no consensus in the literature on the optimal surgical approach. In fact, the Orthopedic Academy guidelines specifically state that there are no clinically significant differences in patient-oriented outcomes related to surgical approach in patients undergoing total hip. And on the right side of the screen here, what you're seeing are basically two diagrams demonstrating different approaches. The image on the top is demonstrating the posterior approach, where you're splitting the gluteus maximus and coming down on the external rotators of the hip, which generally have to be released off of the posterior aspect of the femur to provide you access to the hip joint itself. The image below is demonstrating the direct anterior approach, where we generally go between muscles as opposed to splitting or releasing muscular attachments to access the hip joint. So here you go between the tensor fascia laterally and the sartorius muscle medially to access the hip joint. The posterior approach is certainly the more historically what's been used for hip replacement. There have been several advancements over the last 15 to 20 years that have allowed us to make the direct anterior approach a more reliable alternative to the posterior approach. Technologies have included special operating room tables, which allow us to manipulate the extremity in ways that allow us to improve our exposure of the femur. In addition, instrumentation and imaging techniques have improved that allow us to visualize and access the femur in a ways that allow us to do the surgery minimally in a minimally invasive fashion. So what are the proposed benefits of the direct anterior approach? At least according to Dr. Google, improved muscle preservation. The direct anterior approach allows access to the hip joint without cutting or splitting muscles. Fewer post-operative restrictions, lower risk for dislocation, speedier recovery. There may be some validity to these claims, which are readily found all over the internet on every hospital's website that's doing anterior hips. These are the reported benefits of the anterior approach. But we'll look at the literature and we'll see, are these proposed benefits, do they hold true in actual patients? So we'll look at the surgical approach and the risk of dislocation. So dislocation after total hip is multifactorial, with surgical approach being one of only many contributing factors. Historically, the posterior approach has been associated with higher risk for dislocation. However, modern techniques and modern posterior approaches have much more muscle preservation as well as repair, which has drastically decreased the rate of dislocation with posterior approach. So posterior capsular repair, which was not routinely performed many years ago, is now a routine part of posterior approach total hip and significantly decreases the rate of dislocation. And in fact, multiple studies have shown that the rate of dislocation with the posterior approach and capsular repair is comparable to that of alternative surgical approaches. So this was a 2018 systematic review of prospective studies that compared the early 90-day dislocation rate of direct anterior approach hip as compared to the posterior approach. 13 studies were included, 7 of which were randomized, and what this study found was that there was no difference between surgical approaches on the rate of dislocation. In addition, data from Australian and Norwegian registries do suggest that there may be a slightly higher rate of revision for dislocation with the posterior approach as compared to the direct anterior or the direct lateral approach. In Australia and Norway, the direct lateral approach is performed much more commonly for hip replacement. It's pretty rare here in the US for surgeons to use the direct lateral approach. So you don't see that too much in American studies. Australian Joint Registry suggests that overall the direct anterior approach has a lower rate of revision for dislocation compared to the posterior approach, with a hazard ratio of approximately 1.9 while the Norwegian registry has found that the posterior approach is at greater risk for revision due to dislocation, with a hazard ratio of 2.1 in comparison to the direct anterior approach. The direct anterior approach is at lower risk of revision due to dislocation than the direct lateral approach, with a hazard ratio of 0.7. How about wound healing? Infection and wound healing complications are some of the most devastating complications that can occur after joint replacement. So getting the wounds to heal is, of the utmost importance. What we see is, despite some conflicting data, the direct anterior approach does appear to be at a slightly higher risk for wound healing complications and possibly infection than the posterior approach. This is likely due to the proximity of the incision to the abdominal pannus and the inguinal crease. So a 2014 cohort study comparing wound complications between the direct anterior and posterior approach found a significantly greater risk of found that direct anterior approach hips were at a significantly greater risk of wound healing complications in comparison to posterior approach, with the rates being 1.4% as opposed to 0.2%. Another study found that the risk of wound complications with direct anterior is even greater in obese patients undergoing the direct anterior approach. This 2015 retrospective study compared 716 direct anterior approach hips to 3,000 posterior approach hips, and they found that obesity, defined as a BMI greater than 30, was a strong risk factor for patients undergoing direct anterior approach for developing wound healing complications, with a hazard ratio of 4.3, as opposed to patients undergoing the posterior approach, where the hazard ratio was 1.4. So in the obese patients, the risk of wound healing complications was much greater in those undergoing the anterior approach as opposed to the posterior approach, even though in both approaches they were at higher risk of wound issues. This trend was even more apparent in the morbidly obese, in whom the hazard ratio for wound healing complications with the direct anterior approach was 19 as compared to 3.8 for the posterior approach. Another 2015 study retrospectively studied 210 obese and non-obese patients undergoing direct anterior total hip. The obese patients were found to be at 3.6 times greater risk of wound healing complications in comparison to the non-obese patients. Yet another study, a 2016 study demonstrating an increased rate of deep infection in obese patients undergoing the direct anterior total hip. Retrospective study here, 1,600 direct anterior hips. The rate of deep infection requiring revision surgery was found to be 2.5% in those with a BMI of 35 or greater, in comparison to just 0.35% in those with a BMI of 35 or less. Interestingly, this same group performed a follow-up study in 2018 comparing the direct anterior approach and posterior approach, and found no difference in the rate of infection between the two, regardless of whether or not the patient was obese. So a little bit of conflicting data there out of the same group. A 2019 retrospective cohort study comparing prostatic joint infection in patients undergoing direct anterior and non-anterior approaches. Over 6,000 patients in this study. In multivariate analysis, the direct anterior approach was found to be at 2.2 times greater risk for developing prostatic joint infection than the alternative approaches. So how about the highly reported improved post-operative recovery or speedier recovery? Well, while most post-operative recovery following total hip arthroplasty is multifactorial, the surgical approach does have an effect on the patient's recovery. Post-operative recovery influences hospital length of stay and return to work. These are very important variables in today's time when we're looking to minimize our length of stay, and return to work is, obviously of great importance to patients. Speedier recovery is generally considered to be one of the advantages of the direct anterior approach. Yeah. So this 2018 systematic review and meta-analysis of 20 articles looking at approximately 7,000 patients, the authors found that the direct anterior approach was slightly better than posterior approach in regard to early functional recovery and post-operative pain. The hospital length of stay was slightly shorter in the direct anterior approach compared to the posterior approach. In addition, there was no difference between the direct anterior and posterior hips at post-operative week 2 in the number of patients using assistive devices for ambulation. And finally, there's a 2019 prospective randomized controlled trial that compared direct anterior to posterior total hips. It's a pretty small study, but it was powered appropriately. Only 55 patients were included. 28 underwent the direct anterior approach and 27 posterior. There was a trend toward better functional outcome in patients undergoing the direct anterior approach in the first 3 months post-operatively. However, no observed differences in length of stay, pain, implant position, or complications were found. And beyond the 3 months, there were no differences in functional outcomes. So, is the direct anterior approach a superior surgery for total hip replacement than the posterior approach? I think that's it's certainly still debatable. The direct anterior and posterior approach both have pros and cons. The ideal surgical approach is dependent on many factors, one of which is the patient in front of you. What we saw is that obese patients are absolutely at higher risk for wound healing complications, though this recovery may be slightly speedier. So, we have to certainly weigh the pros and cons of each approach in every individual patient. So I offer both approaches to patients. There are certainly some in whom the direct anterior approach would be a very challenging surgery, and a patient would not be a good candidate for that. They'd be at high risk for wound healing complications, and those I would strongly encourage them to go with a posterior approach. But again, it's a case-by-case basis. And again, a little bit about myself for those who are just joining. Originally from Western Mass, I've been at Tufts for residency, the New England Baptist for my fellowship, and I'm currently a part of Orthopedics New England with Sean Rocket and the rest of the group there, and specializing in adult reconstruction, specifically bringing anterior approach to hips to the group, as well as revision hip and knee. I look forward to working with you all in the years to come.
Thanks, Dave. That was a nice review of the literature. We have a few minutes. If anyone has any joint replacement questions they want to hit Dave up with, I'll get started. It seems like everyone who comes to me wants the anterior approach, and you seem to be intimating that unless you're obese, there doesn't seem to be much of a difference in the literature. What's the deal? What's the stark contrast there? Do you have any thoughts about that?
Why are the patients?
Why is it so popular? Yeah, why is it so popular? It doesn't seem to have such an advantage.
Yeah, I mean, well, it's certainly the surgery that's, you could say, in vogue these days. Like you said, it's all over the internet that the anterior approach is leading to speedier recovery. It's leading to patients getting up and moving around quicker. There is, as I was showing in the literature, there is some data suggesting that these patients do recover quicker. They do better earlier on.
Yeah.
There is absolutely a selection bias in the literature. The patients who are being selected to undergo total hip are they're usually younger. They have fewer medical problems. They're less obese. They are generally motivated patients. And these are patients that would generally do very well with a posterior approach as well. I can say that in my training, I've seen and done anterior and posterior approach hips where patients are up and walking great the same day. And almost all these patients, whether they're anterior or posterior, are going home, if not the day of surgery, the next day. So
yeah,
I would say
that
there are definitely, from my perspective as a surgeon, advantages to the way I do the anterior approach hip. I use fluoroscopy in the OR to prepare the acetabulum and use that to position my implants at the time of surgery. So that allows you to, optimize your leg lengths, your offset, your implant position, sort of in real time in the operating room, which I think is a useful thing for me to be able to do as the surgeon. You can certainly do that to some degree with the posterior approach, though it's more challenging in the OR. But in terms of why the patients are seeking it out, it's hard to say. I think it's a lot of what's reported in the literature, what's reported on the internet, and a person, their friend had an anterior approach and did great, and their friend tells them, oh, you have to have this done. You have to have it from the front. You have to have anterior, and that's what the patient wants. And the reality is that joint replacement is to some degree a customer service industry, and if a patient's convinced that an anterior approach is better and they're going to do better than with an anterior approach, then the reality is they're probably going to do better if they have the hip replacement through that approach. And if they have any issues post-operatively and you do it through an approach that they did not want, that's immediately what they're going to blame it on. So
sure. Can you maybe you can talk a little bit about the kind of the no admission hip replacements and where that's going in the field, the same day going home, because my patients definitely ask about that as well.
Oh, absolutely. So day surgery joint replacement is, it's becoming popular over the past 5 years, but obviously the COVID pandemic and the strain it's put on our hospital systems has really propelled that movement forward. And there's been a lot of advancements that have allowed us to do that safely as surgeons. Perhaps the biggest factor is tranexamic acid. Using that in the operating room has minimized blood loss and post-operative bleeding as well. And that's, one of the biggest reasons patients were staying in the hospital for monitoring and blood transfusions if necessary. And our rates of transfusion are much, much lower. And blood loss is substantially lower. Oftentimes we use cell saver technology as well, which allows us to further decrease the effective blood loss by returning some of that to the patient after the procedure. And in addition, our pain control modalities have improved. We've really recognized the importance of periarticular injection and local anesthetics and preoperative anesthesia as well. So preemptive pain control has also played a significant role in minimizing the patient's post-operative pain. And again, that's played a big role. Spinal anesthesia has decreased nausea and vomiting a great deal, which has also allowed patients to go home.
Is there certain criteria where you say there's no way this patient could be a same-day joint replacement, or is it just based on medical comorbidities that we'd all would think about, such as heart disease, diabetes, et cetera?
Yeah, I think it's nowadays, I'd say you almost have to look at a reason for a patient to be admitted to the hospital, unless they have an active medical problem that should really be monitored closely in the post-operatively, like significant cardiac disease, kidney disease, pulmonary dysfunction. Most patients are a candidate for day surgery if they're motivated. Again, there's a lot of patients who come in and they're convinced that the anterior approach is the right surgery for them. There's a lot of patients who come in and they say, oh, my mom had her hip replaced and she stayed in the hospital for 3 days. And the patient's convinced they need to stay in the hospital. If the patient's convinced that they need to stay in the hospital overnight after their joint replacement, it's going to be really hard to convince them to go home and that they can do that safely. So the patient has to be motivated.
Sure. We only have a couple minutes left. Let's squeeze one more in, I guess, since I see nothing in the chat. What should the patients expect post hip, whether it's day surgery or not, in terms of work and getting around and then getting back to their sport, whether it's golf, running,
Sure.
or cycling?
Yeah. So what I generally tell patients is that most folks are ambulating pretty well around their home. They should be able to mobilize in and out of the office to come back for their post-op visits by about 2 to 3 weeks. By about 6 weeks, most folks are ambulating pretty well. They should be able to do things like walk around the block, go walk around the supermarket, things like that. They should be weaning off of their assistive devices. So there are some surgeons who are pretty insistent that post-operative patients use some assistive device for about 6 weeks just to minimize the risk of a fall, even if they're feeling great. The reality is most patients, if they feel great, they just kind of, put the cane in the closet.
Yeah.
But then by about 3 months, most folks are doing pretty well in terms of their mobility. They should generally by 3 months be getting back to things like golf, or they should be returning to work if they're doing something that requires them to be on their feet most of the day. Obviously if someone's sitting at a desk all day, they're returning to work a little bit sooner. That is typically around the 6-week mark, I would say.
Okay. And does that doesn't change whether direct or posterior as far as the literature concerned, it looks like, unless selection biopsy has bias, as you said. So
yeah, not generally.
And do you have a preference for which one you like to do, or no?
It's a tough question. I find personally, my preference would be to do it in a otherwise healthy, non-obese patient. There are ways for me to do the anterior approach that allow me to optimize offset, leg length, and implant sizing and position through an anterior approach that I like. That being said, I personally I think the posterior approach is a more enjoyable surgery for me to perform. It's a little less physically demanding on me, and but yeah, I like the anterior approach, and I will generally offer that to most of my patients who I feel are reasonable candidates for that, meaning not obese, because I do think the literature is pretty clear that obese patients are at increased risk for an infection and wound healing complications, and I've seen that play out in my patients and patients I've seen in fellowship and residency. And an infection is certainly a devastating complication, and if the patient gets an infection, they're not really going to care about anything else. So
well, great. Thanks, David. Welcome to the medical staff, and thanks for the talk, and we'll put it up on the web. People will check it out. We want to wish from the medical group, wish everybody a happy and a healthy Thanksgiving. Please be safe and try to get out at some point today while the sun's out. It's a beautiful day. Thanks, Dave. Everyone have a nice weekend. Bye.
Thank you.
You're welcome.